Auditory Dys-Synchrony. Auditory neuropathy or dys-synchrony is a form of hearing impairment in which cochlear outer hair cell function is spared, but neural transmission in the auditory pathway is disordered. This is the architecture of the cochlea. This is the inner hair cell, the outer hair cells. This condition or a group of conditions with common physiologic profile accounts for approximately 7% of permanent childhood hearing loss and a significant proportion of adult impairment. The clinical findings that define auditory dys-synchrony are the demonstration of outer hair cell integrity in evoked otoacoustic emission and cochlear microphonic recordings in conjunction with the ability to record evoked neural activity at the level of the eighth nerve, which is compound action potential, and brainstem auditory response. These are the waves in brainstem auditory response. We shall study these a little later. The terms auditory dys-synchrony has been used to describe a form of hearing impairment in which the cochlear amplification, and that is by the outer hair cell function, is normal, but afferent neural conduction in the auditory pathway is disordered. As such, the electrophysiologic result profile is classically retrocochlear, but the exact sites of origin and the pathologic mechanisms involved are yet to be determined. Other clinical features consistent with auditory dys-synchrony pattern include the presence of permanent or fluctuating hearing loss of varying degrees, normal radiologic findings, absence of mid-ear muscle reflexes, and speech perception deficits out of proportion with the behavioral audiogram. Decreased hearing sensitivity can result from dysfunctioning occurring at various sites in the peripheral and central auditory pathway. The most common form of permanent hearing loss is the result of an abnormality at the level of the cochlea and can be related to a loss of malfunction of inner hair cells, loss or malfunction of the cochlear amplifier, and this is thought to reside in the outer hair cells and provide an increase in hearing sensitivity up to 40 decibels or a disruption of the driving force for the inner hair cell known as endocochlear potential. Again, architecture of the cochlea, the inner hair cell, the outer hair cell, and this is the cochlear amplifier. Cochlear level hearing deficit is variously referred to as sensory, inner ear, hair cell, cochlear, and sensorineural hearing loss. The last term has been used in recognition that some cochlear losses may also involve damage to neural elements that occur, for example, as a result of sensory deprivation. Hearing deficit can also be the result of abnormal transmission of neural signals through the auditory pathway or disordered processing of those signals in the auditory brainstem. Such losses, which can produce the auditory dys-synchrony result profile, have been indistinguishable from those centered in the cochlea till the advent of pre-neural assessment techniques. In recent times, however, the combination of pre-neural physiologic measures such as cochlear microphonic and the otoacoustic emission with neural responses such as the compound action potential and auditory brainstem response has made it possible to identify neural transmission disorders in subjects with cochlear function. Auditory brainstem response. The auditory brainstem response arises from activity occurring in the auditory pathway in 10 to 15 milliseconds immediately following the presentation of an abrupt auditory stimulus. These are the 5 waves of ABR. We will discuss these in detail. The waveform complex consists of 7 major peaks that are typically plotted with vertex positive waves pointing upwards and are labeled by Roman numerals. The neural regenerators responsible for the auditory brainstem response are yet to be very clearly defined. However, the data suggests that both wave 1 and wave 2 are compound action potentials, with wave 1 arising from the distal portion and wave 2 from the proximal portion of the auditory nerve. Wave 1 therefore is initiated at the peripheral or distal portion of cranial nerve 8. It should occur at approximately 1.5 millisecond for a click. As we move along cranial nerve 8, wave 2 is thought to originate from the more proximal portion of that nerve at about 2.5 milliseconds. Wave 3 is generated at the level of the cochlear nucleus and should occur at approximately 3.5 milliseconds. Wave 4 is generated in the region of superior olivary complex at 4.5 milliseconds. And finally, wave 5 is generated in the region of the inferior colliculus at around 5.5 millisecond. I repeat again, wave 1 from the distal portion of the auditory nerve 1.5 millisecond, wave 2 proximal portion of auditory nerve 2.5 second, wave 3 at 3.5 millisecond cochlear nucleus, wave 4 4.5 millisecond at superior olivary complex, wave 5 inferior colliculus at 5.5 milliseconds. These later waves are thought to have multiple generators and are thought to have contribution from the superior olive and lemniscal pathways up to and including the inferior colliculus. So we have here wave 1 and 2 from the auditory nerve, wave 3 from the cochlear nucleus, wave 4 from the superior olivular complex, and wave 5 from the inferior colliculus. Auditory brainstem response testing has been in widespread use as both a hearing screening and diagnostic measure for over 25 years. In subjects with normal hearing, repeatable auditory brainstem response waveforms can be reliably obtained to acoustic click and tone burst stimuli presented at levels around 20 decibel hearing level. In years with significant hearing impairment, a reasonably close relationship between hearing level and auditory brainstem response threshold has been demonstrated. Mean auditory brainstem response or behavioral threshold difference levels of less than 10 decibel or less have been obtained in these studies for both child and adult subjects. This close correlation between auditory brainstem response threshold and the behavioral audiogram in subjects with normal hearing allows the subject's audiogram to be predicted from evoked potential findings with a reasonable confidence. Auditory brainstem response thresholds, when responses are obtained, typically overestimate the hearing levels slightly, and response absence at maximum presentation levels is consistent with behavioral hearing levels in the severe to total hearing loss range. Auditory brainstem response in years with auditory dys-synchrony. In years with auditory dys-synchrony, auditory brainstem responses are absent or grossly abnormal at maximum stimulus presentation levels regardless of behavioral hearing level. In such cases, disruption of auditory brainstem response is thought to be the result of either a reduction in the number of neural elements available to contribute to this response or a disruption in the temporal integrity of the neural signal. The main positive peaks in the auditory brainstem response are separated by only 1 millisecond. Thus, successful recording of average response requires that the timing of discharges within the auditory brainstem be almost identical after each test stimulus. Various authors have suggested that a dys-synchrony in the neural firing of the order of fractions of a millisecond is sufficient to disrupt the response and render the average potentials unrecognizable. Cochlear microphonics. The cochlear microphonic is a receptor potential produced by the polarization and depolarization of the cochlear hair cells. As such, the response is pre-neural and shows little or no latency delay from the onset of the stimulus. Starr found that the initial rest peak in the cochlear microphonic waveform occurred in a group of normal subjects only 0.4 milliseconds after the stimulus reached the eardrum. The cochlear microphonic is recorded and extracted from the electroencephalograph in the same way as the auditory brainstem response and appears as an alternating current potential that provides a bioelectric analog of the input and hence therefore the term microphonic. As a result, this potential, unlike those produced by neural activity, shows a direct phase relationship with the stimulating waveform. The cochlear microphonic, through its ability to reflect the integrity of the cochlear hair cells, can play a significant role in the identification of ears with auditory dys-synchrony. As discussed previously, an absence of severe abnormality of the auditory brainstem response at maximum presentation levels in ears with sensorineural hearing loss is consistent with significant cochlear damage. In such cases, the cochlear microphonic would also be expected to be absent. The presence of this response is indicative of at least some degree of outer hair cell and is therefore suggestive of neural transmission abnormality in ears with absent or disrupted brainstem potential. Otoacoustic emissions. An otoacoustic emission is the release of sound energy in the cochlea that is recordable in the ear, and this fascinating discovery was made by Kemp in 1978. This sound appears to be a byproduct of the active bioelectric process that exists within the normal cochlea. This active process, which is thought to enhance both the threshold sensitivity and frequency tuning of the inner ear transduction system, is considered to reside in the outer hair cells. The relative ease with which otoacoustic emission testing can be performed and the fact that emissions can be obtained in subjects of all ages has led to the widespread investigation and use of this response as a hearing screening tool. Although the data has on the whole suggested that the ability of otoacoustic emission based procedures to predict audiometric threshold is limited, emission testing has proven to be successful as a screening measure capable of differentiating between ears with normal cochlea, that is the outer hair cell function, and those with sensorineural hearing loss. Approximately 99% of ears with auditory threshold, audiometric thresholds in the normal range, that is less than 20 decibel hearing level, have recorded emissions for both the transient and distortion product test paradigms. In ears with cochlear hearing deficit, however, the probability of eliciting an otoacoustic emission decreases as the degree of hearing loss increases, such that the transiently evoked otoacoustic emission is absent in all cases with average hearing losses above 35 decibel hearing level, and the distortion product otoacoustic emission is absent for all ears with losses above 60 decibel hearing level. As such, emission absence in a ear with normal middle ear function is indicative of significant cochlear hearing loss, whereas otoacoustic emission presence is indicative of normal peripheral function, that is middle ear and cochlear outer hair cells. The otoacoustic emission response in providing an indirect measure of the function of the cochlear amplifier and outer hair cells offers a means of differentiating between sensory and auditory neuropathy or Dys-Synchrony type of hearing loss. Ears with absent auditory brainstem responses because of sensorineural hearing loss typically show audiometric thresholds in the severe to profound hearing loss range. Cochlear damage sufficient to cause a hearing loss of this degree typically disrupts the active cochlear mechanisms that generate otoacoustic emission, resulting in response absence. Otoacoustic emission presence in ears with absent auditory brainstem response. Again, otoacoustic emission present in ears with absent auditory brainstem response is therefore suggestive of auditory dys-synchrony rather than sensory type of hearing loss. So I repeat again, if otoacoustic emission is present and auditory brainstem response is absent, this is suggestive of auditory neuropathy or auditory dys-synchrony. Possible mechanisms producing auditory dys-synchrony result pattern. Patients with physiologic characteristics that have been broadly categorized as auditory dys-synchrony can present with a range of clinical symptoms. The variability in clinical features seen in this group may represent differing degrees of the same pathology or may be the result of a range of distinct auditory pathway disorders. Some possible sites of lesion include the cochlear inner hair cell, the synapse between the inner hair cell and type 1 auditory nerve fiber, and the auditory nerve itself. Inner hair cell loss. One mechanism that could produce the auditory dys-synchrony result pattern is pathology restricted to the inner hair cells. A peripheral site of lesion such as this is consistent with the observation in auditory dys-synchrony patients that even the earliest auditory brainstem response waves are absent, including wave 1, which represents the first action potential in the auditory nerve. A specific inner ear hair abnormality could result in the decrement of the entire auditory brainstem response complex with the preservation of outer hair cell responses. Again, the inner ear cochlear, the cochlear amplifier, which is the outer hair cell, and the single inner hair cell. These are the waves of the auditory brainstem response. At this stage, the integrity of inner hair cell function in living patients cannot be determined because suitable diagnostic tests are not available. However, biologic precedents for selective inner ear hair cell could be present. The result for these oxygen deprived youngsters do, however, fit with the recent animal histologic evidence that suggests certain types of cochlear insult, notably those caused by prolonged hypoxia, can have a greater effect on inner than outer hair cell survival. The synapse between the inner hair cell and auditory nerve terminals. A disorder at the synapse between the cochlear inner hair cell and type 1 auditory nerve fiber has also been proposed as a mechanism that could produce auditory dys-synchrony result pattern. At the base of the inner hair cell are anatomic structures involved in the storage and release of neurotransmitters. Neurotransmitters act upon receptor sites in auditory nerve dendrites and initiate the generation of action potential. Disorders at this site may be presynaptic, involving the release of transmitters, or postsynaptic, affecting the ability of the receptor sites on the auditory nerve dendrite to respond to these substances. This is the inner ear hair cell and where the synapses with the auditory nerve happen. Mechanisms by which synaptic disruption might occur in the auditory pathway in human subjects are yet to be determined. Genetic dysfunction involving disruption of the otoferlin protein, I repeat, otoferlin protein, which affects transmitter release and has been found in the inner ear cells, however, been identified in subjects presenting with the auditory dys-synchrony result pattern. Again, genetic dysfunction involving disruption of otoferlin protein have been identified in subjects presenting with auditory dys-synchrony. The general symptoms of peripheral neuropathy include weakness and muscle atrophy. These are the general non-auditory symptoms. Muscle atrophy if the motor nerves are involved, sensory loss, paresthesia, which is unusual sensations, and dysesthesia, which is discomfort. The commonly used diagnostic criteria include absent ankle jerks or reduction of vibration sense in the feet, abnormal results on nerve conduction, and abnormal sural nerve biopsy specimens. Generalized neuropathic disorders have been indicated in 40% of reported auditory neuropathy or auditory dys-synchrony cases, and about 80% of patients with symptom onset occurring after the age of 15. The site of the disorder affecting the auditory nerve and the auditory brainstem in these cases may be the myelin sheath or the neuron itself. Myelin disorder. Myelin serves in the central nervous system as an electrical insulator. It is manufactured and maintained by specialized cells known as oligodendroglia. The myelin sheath consists of a lamellar structure of lipids and proteins that wrap concentrically around the axon. Partial or complete loss of myelin can have profound effects on the generation and propagation of action potentials within the auditory nerve fiber. Demyelinization results in an increase in membrane capacitance and a decrease in membrane resistance, leading to a delayed excitation, a reduction in the velocity of action potential propagation, and an increase in conduction vulnerability. Fibers that are demyelinated to different degrees conduct neural signals at different speeds, and the synchrony of discharges can be affected. Although neurons that are not entirely myelinated are capable of conducting action potentials, they do so with prolonged refractory periods and an impaired ability to transmit high frequency pulse trains. Now, as a result, repetitive activation of demyelinated fibers results in a progressive increase in the conduction time of the action potential, and this may lead to an intermittent or total block in their propagation. The pathophysiological changes in neural conduction properties associated with demyelinization are likely to have profound effects on the auditory brainstem response, which is reliant on a relatively precise synchronous response of a population of auditory nerve fibers to a transient acoustic stimulus. Reduction in the temporal synchrony of demyelinated 8 nerve fibers are likely to lead to a significant reduction in the amplitude of average evoked response. Moreover, with more advanced lesions, the propagation of action potential is likely to become increasingly vulnerable and the risk of depolarization block is increased, especially for the relatively repetitive stimulus used to generate the auditory brainstem response. Axonal neuropathy. Axonal damage can occur in isolation as a result of specific disease process or can occur in conjunction with or as a consequence of demyelinating conditions. As such, the functional distinction between myelin and axon related disorders can be blurred in some cases. Axonal neuropathies reduce the number of neural elements but do not directly affect conduction speed. The refractory periods of surviving elements also tend to be normal, allowing a reasonably unimpaired response to high rate stimulus. The classical signs of axonal neuropathy in the auditory pathway are therefore a reduction in the amplitude of the whole nerve action potential and auditory brainstem responses rather than an increase in latency or broadening of these potentials. I repeat, a reduction in the amplitude of the whole nerve action potential. However, the absence of any evoked brainstem response in most auditory dyssynchronic cases means that axonal and myelin related neuropathies are clinically indistinguishable. Accurate differentiation between axonal and demyelinating neuropathies can only really be made from histologic examination of the affected nerves. In the case of auditory nerve, this can only be achieved on post-mortem examination of the temporal bone or the brainstem at the point of entry of the auditory nerve. Peripheral nerve studies can be done by taking biopsy specimen of a small portion of another more accessible sensory nerve, and the result can be used to infer the function of the auditory nerve. For example, analysis of the sural nerve have been used in auditory dyssynchrony patients in this way. Summary: neuropathic disorders of the peripheral nervous system, including the auditory nerve, can result in varying degrees of axonal loss and myelin damage. Abnormal function in the auditory system resulting in the auditory dyssynchrony result pattern may therefore be related to disrupted neural synchrony resulting from myelin damage, a reduction in the number of functioning fibers caused by axonal loss, or in many cases a combination of both. The number of different etiologies have been associated with the auditory dyssynchrony result profile. These conditions can be broadly categorized as transient neonatal insults, infectious processes, and genetic or syndromal conditions. The most commonly reported neonatal conditions associated with auditory neuropathy or dyssynchrony are anoxia and hyperbilirubinemia. Excess of bilirubin, a byproduct of red blood cell metabolism, which is often associated with liver immaturity in the newborn, can be toxic to the central nervous system and can result in significant neurologic insult known as kernicterus. Although many neonates, that is 60%, experience some physiologic jaundice that is not toxic, unconjugated bilirubin can cross the blood-brain barrier and cause icteric staining of the central nervous system. Even short-term episodes of hyperbilirubinemia have been shown to result in both temporary and permanent evoked potential abnormalities, including elevated auditory brainstem response thresholds. and prolonged auditory brainstem response waves 1 to 5, suggesting, therefore, that both the peripheral and central auditory systems are vulnerable to bilirubin insult. Genetic and syndromal factors. The auditory dyssynchrony result profile often occurs as a part of a generalized neuropathic disorder. Hereditary motor and sensory neuropathies, such as Charcot-Marie Tooth syndrome type 1 and 2, make up a relatively high proportion of the adult cases reported to date. Siniger reported that 8 of their 13 patients with auditory dyssynchrony symptom onset at age 10 years or older were confirmed hereditary motor sensory neuropathy sufferers. Charcot-Marie Tooth syndrome is a genetic disorder which involves the degeneration of the myelin sheaths and is thought to be related to an abnormality in the peripheral myelin protein 22 on chromosome P17 or a mutation of MPZ gene. Loss of axons of distal portion of the peripheral nerves has also been reported with this condition. Another inherited disease that is relatively commonly associated with auditory dyssynchrony is Friedreich's ataxia. 4 cases of autosomal recessive condition were described in the Siniger series. Friedreich's ataxia is a neurodegenerative condition that is believed to be restricted to brainstem and cerebellar parenchyma. Auditory brainstem response assessment in patients with Friedreich's ataxia have typically shown either complete response absence or presence of wave 1 and absent later responses. Histopathology has indicated that cochlear neurons and spiral ganglion cells are affected in Friedreich's ataxia, whereas cochlear structures are unimpaired. Isolated cases of auditory dyssynchrony have been reported with other genetic disorders. And now, some of these include Ehlers-Danlos syndrome, an autosomal dominant connective tissue condition related to various vascular abnormalities, and Stevens-Johnson syndrome, a rare cutaneous typically triggered by drug therapy. Auditory dyssynchrony has also been associated with syndromes affecting the immune system, namely the Guillain-Barré syndrome and the mitochondrial enzyme conditions. Age of onset. The age of onset of auditory dyssynchrony type hearing loss has tended to fall into 2 distinct groups: those who present with symptoms in infancy and those in whom the condition develops in adolescence. Only 1 in 4 auditory neuropathy or dyssynchrony cases are older than 10 years at symptom onset. STAR suggests that this comparatively low proportion may be because some of the affected patients lose their emissions over time and as such may not be recognizable as auditory dyssynchrony cases if otoacoustic emission response and not cochlear microphonics are the diagnostic criteria. Another reason for the higher proportion of pediatric cases in the auditory dyssynchrony spectrum could be because of the physiologic test techniques required to identify the condition, namely auditory brainstem response, cochlear microphonics, otoacoustic emission are more frequently used in screening and diagnostic programs in pediatric populations. Adult auditory neuropathy dyssynchrony patients with symmetrical hearing thresholds and reasonable speech perception, for example, are unlikely to be considered for physiologic assessment. Hearing loss configuration. Audiograms with low frequency emphasis, which is a reverse slope, are a reasonably common finding in both adults and children with auditory dyssynchrony. Acoustic reflexes. Abnormal medial muscle reflexes are consistently reported finding for both adult and children with auditory neuropathy. Reports have shown that non-acoustic medial muscle reflexes can be elicited in auditory neuropathy patients by tactile stimulation to the face, suggesting that the efferent components of the reflex arc are intact. Which are the efferent components? The facial nerve and the stapedius muscle. In summary, therefore, the speech perception findings for children with early onset auditory neuropathy or dyssynchrony have resembled their adult counterparts, with many performing on formal assessments at levels poorer than would be expected for years with sensorineural hearing loss of an equivalent degree. Hearing aid performance in subjects with auditory dyssynchrony. Despite the considerable debate that currently exists about the potential risk and benefit of amplification in auditory neuropathy or dyssynchrony subjects. Relatively few studies have presented evidence of aided function, that is, the speech perception results. Anecdotal reports of unsuccessful hearing aid fittings begin to emerge about the time that the condition was first identified. Amongst adults with late onset auditory neuropathy, acceptance of amplification has been universally poor, with the reports ranging from little or no benefit. Therefore, the overall result is that hearing aids have very poor to offer in patients suffering from auditory dyssynchrony. Cochlear implants. Improved detection of speech sounds provided by a cochlear implant offers at least an opportunity for speech understanding in these cases. In addition to improved sound detection, there is also some evidence. I repeat again, in addition to improved sound detection, there is also some evidence that electrical signals produced by cochlear implants may stimulate the auditory pathway more efficiently in some auditory neuropathy dyssynchrony subjects than is possible with acoustic stimulation. So, in these patients with auditory neuropathy, cochlear implants are of a greater benefit. Cochlear implantation is currently the most successful remediation strategy for patients with poor sensitivity and speech understanding caused by auditory dyssynchrony. Most implantees with this form of hearing loss show good access to the normal speech spectrum and speech perception abilities comparable with their sensorineural component. However, because isolated cases with poor results have been reported, pre-neural assessment techniques need to be incorporated into the pre-operative test battery, and candidates with auditory dyssynchrony condition need to be counseled accordingly. I repeat, candidates identified with auditory dyssynchrony condition need to be counseled that they may or may not improve. This, therefore, is a comprehensive review of auditory dyssynchrony.